Hi, everybody. My name is Jill Attaman. I'm a reproductive endocrinology and infertility specialist with Boston IVF. I'm thrilled to be here with you today, talking to you about fertility and infertility and any reproductive questions that you may have in regards to family building or otherwise. Thanks so much for submitting some questions in advance. I'm really excited to get to some of those and then hear if there are any other questions that come into the chat. I am available for you. So again, thank you for your time and let's get started. So the first question that came through was, do you recommend not drinking, smoking, or exercising during the process? And if so, how long before or after injections? So I'm assuming this question has a lot to do with in vitro fertilization, giving the injections. That'd be the most common reason to use injections, or ovarian stimulation for egg freezing, embryo freezing. Generally, we ask that folks are as healthy as they can be prior to any attempts at conception or at family building. So I would recommend that you're not drinking alcohol, you're not smoking, vaping, doing things that are unhealthy for you prior to the process and preparation of having the most successful cycle that's possible for you. In addition, if one is also trying to become pregnant, it's a nice time to make those lifestyle modifications in advance. In regards to the exercising, this question gets asked quite a bit because during a stimulation process, if one is going through IVF or egg freezing, ovaries can get quite large. It's very dependent on the person, but the goal is to stimulate multiple follicles, which are the spaces where the eggs are resting and waiting. And as that happens, those ovaries are going to feel a little bit bigger. One ovary, both ovaries, depending on the number, they feel large. So exercise routine needs to be more modest. I generally recommend lighter exercise. Now, as the ovaries start to become bigger, most people will start to appreciate some pressure in the abdomen, and that's the right time to decrease those activity levels. Going for walks, doing light activities are fantastic. Things that could injure the abdomen, real vigorous activities, twisting, turning, inversions. I generally recommend avoidance of those activities during the stimulation phase and immediately after as well. Hopefully that answers the question. And alcohol is just not good for pregnancy. So if we're planning pregnancy, it's a good time to stop now. Also probably beneficial to stop during a cycle. Smoking is important as well. Secondhand smoke and passive smoke is also quite important for ovarian health. Vaping and the electronic nicotine devices should also be avoided. Not only do those potentially contain nicotine, but other very harmful substances for you. All right, I'll move on to the second question. How many IUIs would you recommend before switching over to IVF? This number is different for everybody. Everybody has their unique journey, and I would say I can approach this in a couple of different ways, perhaps breaking it down into some large groups. So some folks come in with unexplained infertility. That means that there's egg, there's sperm, and pregnancies just aren't happening. If that's the case, and all the testing has returned normal, generally, a typical algorithm would be to try to become pregnant with at least 3 IUIs. If IUIs are chosen as the first therapy, potentially a fourth, and then moving forward with IVF. Now, some individuals would select IVF as an initial treatment option as well. Some of this is dependent on individual circumstances, finances, insurance. Other folks will be going through IUIs with donor sperm, whether it's donor sperm for a person that's intending to be a single parent by choice, or whether it's in a couple that doesn't have sperm, or in somebody that is coupled with somebody that may not have sperm that's adequate for IUIs. That number may be a little bit more lenient. It could take up to 6 months to a year for pregnancies to occur, and different insurance policies will have guidelines for you as well. But in general, we're reconvening after a few IUIs, potentially going up to 6, and then talking about the merits of other options. And again, I have the discussion with most individuals about IVF as initial opportunity as well. Um, Otherwise, individuals may be thinking about IUIs if they're not ovulating and undergoing ovulation induction with medications such as Clomid or Letrozole. And IUIs are reasonable to add in if relations or timed intercourse isn't an option. This may also be a higher number. So again, quite individualized. Maybe I didn't catch everybody in those examples, but hopefully lends a little bit more insight. The next question that was pre-submitted is, what are some of the factors that make somebody have a more robust response to the egg retrieval process? The number one answer here is going to be age. So no matter what we talk about, most people that we see are young and healthy. However, the ovaries age pretty quickly. It's unfortunate, but peak fertility is in the mid to late 20s. So individuals that we see that are aging and beyond their 30s, 35 into the 40s, this is the number one reason why ovaries are a little bit less likely to respond robustly. There are other factors. Body weight can influence how a stimulation process goes. Overall health in general is a large component to how somebody may stimulate. Ovarian reserve would be one that I should not overlook and should have listed as an initial. So we can try to predict ovarian response and robustness of ovarian response based on some early ovarian reserve testing, things like an anti-Müllerian hormone. This is a hormone that comes from small follicles within the ovaries, will help predict response. Gonadotropins, such as FSH and LH that come from the pituitary gland, and the amounts that are being secreted will also help predict response. And then an antral follicle count. An antral follicle count is a physical assessment of follicles, so the spaces where the eggs are resting and waiting in the ovaries can be visualized on an ultrasound. It's not an absolute number of eggs that are there and available. So if you are having an antral follicle count or just came back from having an antral follicle count, that's not the absolute number of eggs you'll have for your lifetime, but it's a reflection of what may be recruited should you select to use stimulation medications during that particular cycle or a cycle near that month, for example. So those would be the largest factors. And again, forgive me if I'm excluding anything here. Smoking is a good example that I probably should have put in here. I would decrease smoking to enhance responsiveness, avoidance of things that are unhealthy for you. Next question would be, what is the ideal age to freeze your eggs? Great question. I think that we spoke to that just a little bit. Ovaries start to age in the mid-20s. So ideally, I would say an individual less than 30, if the goal is to be to freeze eggs, would be ideal. So late 20s, early 30s. This also gives individuals a time to think about whether this is the option that they'd like to pursue. In general, when I talk to individuals about egg freezing, I also do ask about when a pregnancy may be planned, if there are any plans for an upcoming pregnancy. If eggs are being cryopreserved and pregnancy is being planned in the very near future, that leads us down different conversations. Sometimes thinking about embryo cryopreservation for fertility preservation as well. Please tell me more about PGTA testing and the IVF process. So PGTA is pre-implantation genetic testing. And this is where embryos are created through the IVF process, so in vitro fertilization, stimulating ovaries, retrieving eggs, combining eggs and sperm in a culture environment, and then allowing the embryos to develop until the fifth, sixth, and sometimes up to the seventh day of development. At that point, an embryo may have about 100 to 200 cells in it. If it develops into a high quality blastocyst, one that could likely survive a freeze and a thaw process, then embryos may be screened. The screening involves removing a subset of cells from that embryo. It's maybe 5, it may be 10 cells that are removed. Those cells are then sent to a genetics laboratory, which is how we currently perform our testing at Boston IVF. The embryos are cryopreserved, and then we receive a report back in the weeks to come that will identify whether the cells that were sent are likely to be euploid, meaning normal chromosome number, so 46XX, 46XY, or likely to be aneuploid, perhaps an abnormal chromosome number. And a common example of this would be a trisomy 21, which is an extra 21st chromosome. Now, the embryo screening is truly a screening test. We still recommend first trimester diagnostic testing if that is the goal for you and your pregnancy to confirm the results. You did mention learning sex chromosomes like X's and Y's, and if that information is something that you're interested in, this is the technique that will allow you to gain that information. All right, so now I hope I answered that adequately. I'm going to go into the chat and read some of the questions that are coming in. The first question is asking about transporting an embryo from another country. So there are specific regulations in some countries regarding transport of embryos. So that's the first thing that I would look at. And then generally it is linking in with a physician at a particular clinic that you're interested in. The process is different for everybody, but it may involve embryology to embryology communication. So the first point would be to establish yourself as a new patient, so that could be determined. You can also look into some of those transport guidelines to make sure that the embryos can actually be transported from the country in question. The next question I see is, unfortunately, a last transfer didn't work. I'm sorry that it didn't produce the outcome that you were hoping for. And it looks like there are questions about lifestyle adjustments to talk about increasing an endometrial lining thickness. This one's a little challenging. It depends on a few different factors. So sometimes there's something inherent to an individual that would lead to the endometrial lining being a little bit thinner. So an embryo transfer is when somebody will come in after an embryo has been created and the embryo is placed into the uterus with a very gentle procedure, generally under ultrasound guidance. Most of the time, folks are just pretty uncomfortable because we ask that a bladder is full so that we can see. But when the lining is less than a certain number, some people get a little concerned that the embryo transfer may be less successful. The data is pretty variable here, but there may be something inherent to an individual that would cause the lining to be a bit thinner. It doesn't necessarily mean that a pregnancy will not occur, albeit we generally have some goals that we work with in regards to endometrial lining. Lifestyle modifications that could be made may be a little tricky. I would say anything that you can do that leads you to be a healthier person is likely to lend itself to a healthy uterine environment. Perhaps thinking about things in your environment as well could be beneficial. Anything that you might be exposed to that could be changing your hormonal profile internally. And these are things that we can encounter occupationally, we can encounter at home. I don't have one best answer for you. There are protocols that you'll probably talk to your doc about that could involve different ways to try to help an endometrial lining if they think that that's the primary etiology for the pregnancy test that didn't turn positive. I wish you the best. For PCOS, this is the next question. Do I need more cardio workouts along with my strength training? Gosh, I'm going to sound like a broken record here, but I absolutely promote exercise. Strength training is great, cardio is great. It can be really beneficial if there is a goal for weight reduction. Some individuals are quite lean, and too much weight reduction may be detrimental. So there is a little bit of a difference depending on what you are and who you are as an individual. But I would definitely work on both in general for polycystic ovarian syndrome because it is associated with metabolic concerns, higher blood pressure concerns, impaired glucose intolerance, cardiovascular disease, abnormal lipids and cholesterol. So all of these things that you do, cardio and strength training, will help decrease that. If you have any further questions in regards to nutrition, I think a nutritionist is an amazing option as well. There's great resources online with nutritionists and in-person folks. And we have an amazing group through Boston IVF as well, in case that's ever an option for you. All right. Next question would be, can you be breastfeeding and have a transfer? This is a question I'd ask your individual physician. My general practice is to advise cessation of breastfeeding prior to an embryo transfer to make sure the endometrial lining is as healthy as it may be in the uterus, is as receptive as it can be for that next embryo transfer. Embryos are pretty precious, so we want the best for them. All right, the next question as they keep coming in, how long is a standard IVF cycle? So a standard IVF cycle may include a pre-treatment phase. So this is when folks may use oral contraceptive pills, progesterone-only pills, estrogen beforehand, estrogen and a medication called an antagonist, or you may just start with the stimulation phase. So we have pre-treatment, then ovarian stimulation. The stimulation phase is where you use injections of hormones. The hormone profile may be different based on who you are and who your physician is and what they think will be best for you. It may involve follicle stimulating hormone, Menopur, which is a mixture of LH and FSH, or HCG. So there's a variety of different protocols, but in general, the injections will last for, I would say, around 10 to 12 days. This is variable based on your pre-testing and age and goals. But the actual injection phase is probably around 2 weeks, if we want to be pretty vague about it. During that time phase, most individuals are coming in for some amount of monitoring to watch follicular growth, as well as estrogen levels and perhaps other hormones such as LH and progesterone during the process. That may happen 4 times during the cycle. It could happen more frequently depending on the response. At the final day, on the final day, where it looks as though there's a good number of follicles that could contain mature oocytes, a medication is used to complete the maturation process. It's an injection or two, again, individualized and personalized for you. And then you have an egg retrieval. An egg retrieval, if this is being done for yourself, will be approximately 36 hours later. And that could vary based on who you're seeing and your individual history as well. The eggs are then removed the same day. If they are being combined with sperm, will be fertilized with sperm. The next day, fertilization results are known, and the embryos are generally followed for either 3 or 5 days of development for an embryo transfer. All right, hopefully that helps. It can be a little bit longer depending on the pre-medication phase. It can be a little bit shorter. but at least a couple weeks of active monitoring and injections would be the best way that I could tell you to remember the time frame. Okay. The next person is asking me about 2 IVF cycles that didn't work. And the person is 38. Can a third cycle occur? I'm sorry, the first 2 cycles weren't successful. I would recommend that you talk to your physician to look and see if there are parameters that may be altered for a third IVF cycle. But in general, yes, most individuals can go forward with a third IVF cycle or wouldn't be discouraged from it. However, this is very dependent on how the response was during the first 2 cycles and if there's something that's identifiable that made it more challenging. But I'm very hopeful that a third cycle will go well for you. Let's see, the next question. Some common symptoms of PCOS are irregular periods and high BMI. This individual was diagnosed with PCOS with normal periods. Almost none of the other symptoms. How does this affect fertility chances? So some of the other symptoms that are being referred to would be the clinical hyperandrogenism, and this is when individuals that have higher levels of testosterone or the androgens, the hormones in the system, that can cause concerns like acne, hair growth, thick, dark hair growth, lip, chin, belly, back in different places, scalp hair loss, that's more of a male pattern hair loss. These are some of the symptoms that doesn't sound like the individual's having very many of. Very good opportunities for pregnancy. And if you're continuing to have normal periods and ovulate regularly, you have different options. I don't know how long pregnancy attempts have been occurring, but if it has been a duration of time, you'll likely be offered different treatment modalities. This could include ovulation induction with medications. Common medications used would be Clomid or letrozole and may or may not involve timing intercourse, performing an intrauterine insemination, depending on the individual parameters. But yes, I think you hopefully have a very good opportunity. The next question is moving on to how to improve egg quality. Good health. Good health, avoidance of things that we know that are not okay for you. Avoiding plastics, things that are in plastics that are not good for you. Not smoking, not vaping. Being as healthy as you can. So managing any medical concerns that you may have can help to improve how your eggs respond to medicines. Egg quality itself, the largest determiner is age, and generally that's pretty difficult to change. I think birthdays are wonderful. They're just not amazing for the eggs and the genetics of the eggs and how eggs go on to divide into embryos. Some people will use things like multivitamins. I always recommend a prenatal vitamin. It gives you a good balance of everything, and folic acid is best in your system prior to a pregnancy, if pregnancy is something you're planning. There are other antioxidants, things such as coenzyme Q10 that some people will use, or fish oils, which are now very commonly in prenatal vitamins or in multivitamins. But overall, egg quality is most likely governed by the date of birth. All right, the next would be endometriosis. I keep hearing to advocate for testing for endometriosis. Endometriosis is very common. It's very common in individuals that present with infertility. Um, Advocating for endometriosis is a bit challenging. If I'm interpreting the question correctly, it's advocating for testing. The best way to diagnose endometriosis is truly with a laparoscopy, which is a surgery where camera's going through the belly button and then a little bit lower down on the abdomen, and it's a visual assessment for endometriosis. There are other ways aside from surgery to look. Sometimes ultrasound is pretty obvious if there's advanced endometriosis. One could see endometriomas, which are cysts that develop in ovaries because of endometriosis. Also, some ultrasounds can assess how the uterosacral ligaments look, which are um, parts of the pelvic anatomy, how easily ovaries and the uterus move in response to the ultrasound, because endometriosis is also a disease that can cause scar tissue within the pelvis itself. So there are ways to look at this with ultrasound. There are also ways to look at this with a specialized endometrial biopsy. Most of the time, treatments for endometriosis are very similar to treatments that are recommended for unexplained infertility, which is extraordinarily common as well. So something like in vitro fertilization would be offered despite knowing for sure whether endometriosis is present or not. And it's not trying to ignore if endometriosis is there, but IVF is a very good option for endometriosis. Some people would also opt for medications and IUI. If endometriosis is causing significant pain, then a surgical course certainly may be something to be considered. So from a gynecological standpoint, I encourage that you think about how you're feeling. Sometimes there's pelvic pain, significant pain with periods, pain with intercourse. These are some common symptoms. I hope that's not the case for you. All right. What are my thoughts on the male factor side of things? Hello. Um, Absolutely important and so common. So when we do male testing and thinking about male history, we can find a component if there's a person with sperm partnered with the person with eggs 40 to 50% of the time. So I definitely recommend testing. So not only looking at ovarian reserve, which we've talked a little bit about, but looking at the uterus, fallopian tubes, and if there is a partner that has sperm, a semen analysis, and taking a full history to think about exposures, both occupational, environmental, medical history, everything that we've talked about for somebody with ovaries as well. Thank you for the question. Okay, the next question that I'll move on to is my age is 38 and I've done 2 IVFs that are not successful. Is egg quality and quantity a concern is what I'm gathering from that question. Very similar, our last 38-year-old, it sometimes just takes time. Hopefully it's a next cycle for you if that's a reasonable option. Most of the time it's the embryos. They're much more commonly to be aneuploid because of age. These risks change fairly dramatically at 40. They start to change at around 32, and I say 35 is when we start to talk about it. So you definitely kind of move backwards there, but you are in an age range where it can be difficult for those eggs to develop into normal embryos, normal meaning with the correct chromosome number. Quantity can also be a concern. Most people don't go through significant ovarian changes that cause menopause until the 50s, but there can be some diminished ovarian reserve. That's a challenge as well. And that would be looking at, other factors in health as well as are there different ways to stimulate ovaries that could potentially be beneficial for you and would require individualizing it with your physician. The next question relates to endometriosis as well. Do you recommend getting surgery before embryo implantation? There is, or is there a chance that IVF will work even with a mild case? Absolutely. IVF can be used when there's mild endometriosis, even if it's just suspected or presumed mild endometriosis. So I don't generally recommend surgery unless it's indicated for other reasons, such as those GYN reasons or gynecologic reasons I brought forth a bit earlier. Otherwise, in vitro fertilization can absolutely be used. Thank you for doing this. Hey, you're welcome. Thank you. That's kind of you. Do I recommend acupuncture to improve transfers? This is the next question, by the way. Um, I think acupuncture is amazing. If it makes you feel good, it leads to stress reduction. It's not too expensive for you or creating stress to get to appointments. And if you don't find it stressful to be there, then I think there's some definite benefit to taking good care of yourself. And acupuncture is one way to do that. Things that we often don't talk about as much as well would be sleep and a good sleep pattern. Mindful living, I think, is very important, and stress reduction in general. Okay, I'm going to move on to anonymous next. If a patient is having a miscarriage after conceiving 2 to 3 times, what would be the best protocol? That's a tough one to answer. I wish I could answer it more directly, but most of the time, if there's been recurrent pregnancy losses, so 2 to 3 pregnancy losses, I'd be recommending looking at potential etiologies as a first step. So possible etiologies could be abnormal chromosome complement of egg or sperm. It could be something called antiphospholipid antibodies, could be an abnormally shaped uterus. There are other factors that can be at play, such as inflammation of the endometrial lining and a host of other things that may be individualized for you to try to assess why losses may be occurring. And there's no one best protocol. If you know that losses have been because of abnormal chromosome complements, some individuals would add on PGTA to look at the genetics of the embryos, knowing that the preference would be not to transfer back an embryo that's likely affected, but that doesn't fit for everybody, whether it's for a variety of reasons, but that may be one option that's brought into the conversation as well. All right, so let's do a few more here. I am a 32-year-old female. What are the long-term treatment options with someone with blocked fallopian tubes? So generally, this depends a little bit. If the fallopian tubes are blocked proximally, so let's assume that a uterine cavity evaluation and a tubal assessment, whether it was with a hysterosalpingogram or something we call the hycosi, which is a similar test where water is introduced into the uterus and then water is placed through the fallopian tubes. If they're blocked at the entry point to the uterine cavity and they're not dilated, then in vitro fertilization is a really good option. That's a more difficult place to perform surgery. There are some surgeons that specialize in tubal reconstruction, but generally it's blockages that are in different places. And I would defer that question to one of those surgical specialists, since I no longer do that type of surgery. If the tubes are blocked and dilated, meaning they're full of fluid or full of dye, and they look like they could have fluid that may flow backwards into the uterine cavity, or they look inflamed, where they could be creating substances that make it less likely that an embryo would implant. Your physician may talk to you about either blocking those proximally, if need be, or removing the tubes, which would mean that IVF would be used for future conceptions. But that can help increase pregnancy outcomes and implantation rates. Okay, next question. What is the recommended path after recurrent pregnancy losses? Should we go straight to IVF or try IVF first? I'm assuming that's IUI versus IVF. I apologize if that's an incorrect assumption. Very dependent on you and what you feel would be the better course of action. Either are options for you. If you've been trying and there's hasn't been success, and then medications and things like IUI can help. IVF is also an option because it does give you the possibility to screen embryos to look for chromosome complement and know if an embryo that's being transferred back is likely to have the right chromosome number or not. No one best answer. Also very financially dependent. The screening tests aren't perfect. Um, a lot to take into consideration with that question. I'm sorry, I won't be able to answer it, and it's full with the full attention that it needs. Okay. And let's see. What are the chances that I will be able to conceive with an unassisted manner after having a successful IVF baby? Well, hopefully that means congratulations on a successful and hopefully healthy little one. This individual is young and has a blocked tube. So it's still a good probability of success, given a young age that's listed here. However, there's also many individuals that will say, you know what, I tried for a year for my first pregnancy and I just don't want to wait another year for a second. And that would be secondary infertility, and fertility care would be very warranted at that point as well. Others are thinking maybe, two and two alone in the family in regards to children, in which case, taking a little bit of time to see how that goes is also very feasible. A lot of the predicting that I could do in regards to success would be based on some of your individual parameters, but mostly it's the time to next pregnancy. So a lot of individuals will conceive after first IVF because there's also a great chance that somebody would conceive prior to a first IVF, just lower. I guess I should take back the word great, just lower than what one would like it to be, therefore leading to a longer time to pregnancy, which is when fertility care comes in. I'm sorry if I was a little backwards on that one. All right, so it looks like we are good on questions. Last one here. What's a recent development that I'm excited about? Great question. I get so excited about so many things with IVF. I totally love this, and I'm so passionate about in vitro fertilization. There's so much that I'm learning every day that I think is extremely important and helpful. I don't know if there's one right answer to that. Um, I think what I'm most excited about is learning about different ways for frozen embryo transfers and how to help decrease and improve pregnancy outcomes. I mean, help improve pregnancy outcomes for the healthiest kiddo. I think I've also really been excited that this shift over years to single embryo transfers, I think that's been a big shift, and something that I'm really excited to have been a part of throughout my career. And I look forward to so much more. Thank you. I want to thank everybody for being with me today. I really appreciate the questions. Super excited to hear some good outcomes, or for you to have some good outcomes, and have an amazing rest of your day or evening. Take care.